Today we are chatting about community paramedics and paramedicine. And so what is this thing anyway? What's it all about? And all that kind of stuff. So everything you always wanted to know about community paramedic, but we're afraid to ask, here we are. So welcome, Clara.
Hi, Chris. How are you?
Well, I'm doing pretty good. So you're a community paramedic.
I am. My name is Clara Kessel. I am a community paramedic. I have been in EMS since the year of 2000. I started my career in New York City as an EMT and then a paramedic. I relocated back to North Dakota, which is where I'm originally from, and got into EMS there and learned about community paramedicine there and saw a huge need in the rural part of North Dakota. So I actually went to school 7 years ago now, became a community paramedic and piloted the program in southwestern North Dakota. And I am presently in the Twin Cities for 5 years now, and I'm the supervisor for the Greater Minnesota Community Paramedic Group for North Memorial.
Is that all?
That's it.
You've done a few things in your time. That's great. And why did you said you saw the need for community paramedic in the North Dakota area, but what do you think was lacking or needed to be added to, or whatever the right word is, that really drew you to that, or you saw as a gap?
Sure. Well, I grew up in that area and, left at 18 years old. And then really all my exposure to pre-hospital medicine was New York City, where if something happened, you had access to a trauma center, stroke center, cath lab, within blocks. And then I got back to southwestern North Dakota, not too far from Theodore Roosevelt National Park, where it was 25 miles plus in great weather to get to a level 4 critical access hospital. And it was another hour and a half beyond that to get to a level 2 trauma center. And at the time, North Dakota didn't have any level 1 trauma centers in the state. So it wasn't just access to any, it was access to any care. It wasn't just specialty care. And so, especially working in those rural areas when people are out on their farms, and that's where they've lived their entire lives, and the roads are bad, and they don't want to necessarily admit that they can't do what they used to because they're afraid of leaving their home, then the healthcare needs to come to them. And that's where community paramedicine had a beautiful fit in that region.
Cool. And then you came to Minnesota, and I've heard it said that if you've seen a community paramedic program, you've seen a community paramedic program. In other words, they're so different from place to place in their mission and what they do. Do you find that?
Very much so. Very much so. So in North Dakota, we were really focused on rural care, aging in place, making sure people had some of their basic needs met. Then I came into Minnesota and started working for North Memorial, where it was more focused on urban community paramedicine. So completely different way of looking at things. Instead of care in general, it was, what are the social determinants of health that are affecting these people? They're 10 blocks from a hospital. Why aren't they getting the care they needed? What's the breakdown? Where are gaps? What's the communication that's not happening? Or where are they not being served? So you see it a lot with chemical dependency and mental health patients. Or another thing we see outside of the economic portion of it is people don't have great social structure. So they don't have the neighbors who look out for them or will stop by if they haven't seen them in a day or so. So I think there's very different dynamics. You go from not having any care at all, or it being an extended distance away, and then you come into an urban area and the care is right there, but there's still this huge disparity of why people aren't getting it. And so it's figuring out that piece of it. And then in the greater Minnesota regions, some places it's a combination of both or one or the other. But really, one of the things I love about North is we're specializing the programs in each region to meet the needs of the community that the regions are in. And that's what community paramedicine is all about.
Cool. So you're part social worker. To a
little bit
large
of
degree,
everything.
and part primary care, and so you're doing a little bit of everything. And what I hear is the programs are tailored to your geographic area and your demographics and what's going on there socially, environmentally, all those kinds of things. So other ambulance services or other EMS agencies, I should say, have community paramedic programs throughout the country and throughout our state. So you'll find the difference with and among those services is my assumption.
Absolutely.
What so the million dollar question is, I just thought of this, and for those of you watching, this is just kind of we don't have any script. We just decided to talk about community paramedicine, so just kind of things that pop into my mind. But how was community paramedicine different for you guys during COVID? Was how did that change what you were doing?
So it changed it on a lot of levels. I'm going to go to the patient part of it first because that's always what draws me. So when you have people who have chronic diseases that they're trying to manage and they have a lower immune system and they are terrified to leave their homes, then we need to find a way to get the care to them. And it was the whole, complete PPE in and out because we wanted to keep them as safe. So whether it was they needed their routine labs drawn or they couldn't connect with their primary and they really needed to. And people were legitimately terrified, as you know, to go into their clinic or hospital systems. And so what was happening is their chronic conditions were greatly worsening. And so we tried to fill that gap of not only coming in and doing their labs and everything like that that needed to be done for them, but also then connecting them to their primary care through telemedicine. And we didn't just do that with our organization, we did it for anybody who got referred to us through our hospital system. So they might have been a Fairview patient or Park Nicollet, and we were seeing them to connect them to their primary. So that was one aspect of it. Another thing we saw pretty early on was when everything had started closing down, we saw a huge need from our mental health providers that they were getting really concerned about these people who were shutting themselves in. Some people were having problems leaving to get food, either because of affordability or because their mental health was literally incapacitating them and they couldn't leave their home to get food. And so we would get referrals from our mental health professionals and we would go just drop a box of food for somebody just to make sure, again, those basic needs are met. So in the patients that we were already kind of seeing, I feel like we became kind of their social touchstone because a lot of them did become isolated. And so we were kind of their connection, which, as we know, that human connection sometimes has a huge mental health component to it. So those are a few of the ways.
Yeah, absolutely. No doubt about it. And anybody who knows me knows I'm convinced that the majority of our calls anyway, even in mainstream EMS, if you will, are due to loneliness. Actually, I think there's a lot of social isolation, even in non-COVID times. And I think it's really important for mental health, physical health. Just we're designed to be social critters.
Absolutely.
So what does a day of a community paramedic look like where you are? I had the fortune to ride along with one of your people, so I got a glimpse, but what does it overall look like?
So typically, one of our days starts by going and grabbing our equipment, of course, and then generally signing into Epic so we can get some background on the people we're seeing that day. So we'll go check out our schedule and then we'll go and actually do some research into our patients and whether that's through their recent labs, discharge summary, why they got referred, how they got referred, and in some of those notes, it's what the patient's expectations are of the visit, because we want to make sure that we're not only meeting the goals of what we're referred for, but also that the patient's goals are being met too.
So
Sometimes,
I'm gonna back up just for a second,
oh, that's
just in
okay.
case some of our folks don't know what Epic is. Can you say something just really quick about that?
Sure. Epic's the electronic charting system that our hospital system uses, and we also have capabilities of using it. So it just allows us to go back and look at the patient's medical history, things of that nature.
Cool. Sorry for interrupting you. I just dawned on me that maybe not everybody knows what Epic is.
No, that's a really good point. So yeah, we do some research into the patient. If we're doing wound care that day, we will either get our supplies from our base here, or we will go to the hospital if we need some specialty stuff from trauma services. We see if we're seeing any bariatric patients, because then we might need to bring our EPOC, which is our point of care testing. So like a mini lab on scene that can run a basic metabolic panel. And then we generally call our patients. let them know about what time we're coming. If there's anything we need to address specifically, we do advanced care planning with our patients. So if we know that's something we need, we want to make sure that we have all the necessary documentation with us. And then we kind of log on and hit the road, and we go patient to patient and spend time with them. Sometimes if a patient is having difficulty getting medications, we might stop by a pharmacy and pick up their medications for them.
Good
So
service. That's nice.
yeah,
That's the extra mile right there.
yeah, we just want to make sure that they have everything they need for their success. And some people just are a little more challenged with some of those things than others. So yeah, so then we basically go in, see our patients again, making sure what the referring providers needs are met, that the patient's needs are met or the customer's needs are met. And then we do some basic assessments. We do fall risk assessments, home safety assessments. And really, I think one of the biggest benefits of community paramedics are we're paramedics. We're used to walking into people's houses. We're non-judgmental. We're good at putting people at ease. And so we can take a glance around without people feeling judged or uncomfortable with it. And we can see where those breakdowns are happening and then help find the resources to bridge them. Because community paramedicine is really about taking care of the whole patient and not just this one medical problem or these two medical problems. It's the whole patient.
Yeah,
Yep.
no, it's something that we don't always think about in on a regular day in EMS. Walking into somebody's house, we might note something, we might see something, contact a social worker at a hospital or something, but and that's about the extent of it, right? It's hard to do other things long term.
Yeah.
So can I, as somebody getting into this profession who may be watching this, who is already a paramedic, can they expect to do a rig check or a gear check like you do in the morning before? Do you have an inventory? Do you have to fill out the forms and do all that stuff?
You in our organization, you don't, you're kind of responsible for your stuff. So as far as we carry a backpack, and in our backpack, we have all of our vital sign stuff. We have a lab draw. We carry wound care. Trying to think of a few other the things. We carry an anaphylaxis kit just in case we run into that, but we're responsible for it. So that onus is really on the community paramedic. There's a lot of autonomy in this. There is in paramedicine as well, but you don't have your partner to rely on in community paramedicine. So you get really good at using your resources and being really responsible for your own space. That's one of the reasons I say we check our schedule at the beginning of every day and see what the needs of the individuals we're seeing are. Because if we need something specialty, it might require us running by a clinic to get a special tube that we don't carry because it's a special lab. Or it might require us going to trauma services because we don't carry the specific packing they want us to use on this wound.
Sure. So since they're scheduled appointments for the most part, I'm sure there's things that pop up, I would have to imagine, but because they're scheduled, and just thinking of the safety, everybody's probably concerned about the safety aspect and going into homes by yourself. At least anybody in EMS is, because that's been drilled into us at the start of our EMS education. Scene safe, right? And is there a check-in process so people know where you are, or do you just, like, if you want to know where somebody is, you just see the schedule? Do they call dispatch? Do you as a supervisor know their itinerary, and if somebody wanted to surface for a while, you looking for them? How does that work?
So what we use at North Memorial is called MPS. It's a mobile positioning system. So at the beginning of our day, we log on. And so if I was working today, I'd log on as CP3. And when I go out to the address, I put myself out at that address, and it automatically populates an event in dispatch. And then they check on me every 20 minutes. If there was a reason that I wanted them to check on me more frequently, we see domestic violence patients. And so sometimes you might want a 10-minute status check, then we have that capability. Or if we're going to be with, let's say we have an elderly patient who's 80 and hard of hearing, and the radio kind of going in the back is a little, we can, if we feel safe and we know we're going to be there 45 minutes an hour, we can also take ourselves off the timer and then just clear ourselves from the call and we go. And that allows us to see where somebody is throughout the day. And I generally most mornings check my people's schedule because they're in a lot of different places, and just get an idea of the types of patients they're going to be seeing. And in the smaller, I don't want to say, smaller, yeah, in the non-metro areas, law enforcement also in some of our regions monitors some of the channels just so they can hear where the CPs are.
Sure.
So,
And the smaller communities, so they probably have a good rapport with their law enforcement, know who they are, and et cetera. So,
absolutely.
hey, when I rode along, and I'm typical paramedic, I'll just like switch topics on a dime here. So sorry, everybody. Wow, you're probably doing it too out there. So when I rode along, I went to Bloomington to a hotel with the CP, and there's a room that you have there, like a medical aid station or evaluation station. That was a pretty interesting to me. This just popped into my mind. What can you explain what was going on there and what you're accomplishing?
Absolutely. So St. Stephen's Outreach had set up a homeless shelter within a hotel down in the Bloomington area. And I know they had at least several floors. I don't know if they had a wing. I don't know if they had the whole hotel.
Yeah, I don't know either. When I went
Yeah.
there, yeah, we had one room, and I'm not sure where everybody was. I knew that they were there.
Right. So I know they had multiple rooms that they were utilizing it as a homeless shelter. And because it was COVID, because again, the homeless population tends to be very underserved when it comes to their medical needs, they embedded a community paramedic within the homeless shelter during office hours, certain days and times, so that people knew that they could come in and they could address their medical issues. And if it was something bigger than wound care or something superficial, a COVID test, then we would connect them through telemedicine with Dr. Tangy, and we would have them have that physician visit and then get them what they needed that way.
And Dr. Tangy is your medical director. And
Yes.
he's whose license everybody works under, but there's also a relationship with primary care providers too, right? There's like a dotted line to them. Can you explain that? Here I am jumping around again. You can finish on the hotel thing if you want, but I'm just now I latched on to, so what is that relationship between the primary care physician and the medical director?
So the primary care physician and the medical director have a amazing relationship. Primary care has really embraced community paramedicine because they see the benefit it's had for their patients. And so it's never been, I've never seen any headbutting. It's always the primary care physician knows that if we're reaching out to Dr. Tangy, that it is to help facilitate the care of their patient. It's either because it's after hours, which is very common. You know, somebody gets discharged from a hospital at 4:40 on a Friday, and we're scheduled to go see them at 5, and then we find they don't have A, B, and C, and it's not going to be a good weekend for them without it. We don't want them to go back into the hospital. So we'll connect with Dr. Tangy, and Dr. Tangy has an amazing relationship with the physicians. He works side by side with the primary care.
My guess is he knew many of them prior to this, but he probably spent a lot of time cultivating those relationships too, meeting with people and getting to know them.
For sure. Absolutely. And even when we see, so we get let's say we get a referral, and it isn't necessarily somebody that we plan on connecting Dr. Tangy with, but they have a need and we can't reach primary care, then we always find a way to loop the primary care in. So if this happens on a Friday and it's not our hospital system and I can't necessarily route them a note, then it's reaching out to their clinic and having them go in and check it this way and making sure that they're still aware of what's going on with their patient so they don't feel like somebody else is just intruding or overstepping or anything like that.
Sure. In medicine, like any other profession, can get a little territorial if we're not careful, right?
Exactly.
No,
So,
it never happens. So my other question is that this kind of raises in my mind is, do you serve areas? So obviously North Memorial operates the service. Does a community have to have a North Memorial clinic in it for you to serve that area? Or is that not a deciding factor? Other places I hear mixed opinions on that. So what's North's stance on that? Or what do they think?
so community paramedics don't have PSAs like our ambulance services do. So generally, we get referrals a handful of different ways. They either come from our clinics, from primary care. They come from our EMS providers. Like if they come and they respond to a 911 call, there's a way for them to generate a referral to us if they see something that makes them, and we have a criteria that makes them believe that this would warrant a community paramedic visit. We get referrals through what we call TCM, transitional care management, and that's when somebody's been hospitalized and they get released. And upon their release, that the social worker, physician, charge nurse thinks they would benefit from community paramedicine because they don't have good social support, or they've gotten a new diagnosis, or they're not sure they understood the education that went with something, or they think that for whatever reason they're going to fail once they get out of the hospital. And then we have hospital to home, because TCM is really a Medicare kind of thing. And hospital to home is seeing patients under the exact same criteria. We just may or may not connect them with the physician via telemedicine based on the patient's needs.
Okay, so I'm hearing whether there's a clinic in the area or not is not mission critical. It's about who the system is serving and those kinds of things. So there may not be a clinic there. Are they predominantly North's patient population, or do you I don't know if this is the right word, subcontract with other systems to do work other places, or would you do work for another hospital, or how does that or is it just a North focus?
Oh, it's definitely not a North focus because none of our greater Minnesota regions have either a hospital or a clinic anywhere near them. So what we do is we do some contract work with them. We see Medicaid patients from every area, and we see EMS referrals from every area. But we have had meetings when we go out into these other areas with other systems because we have no presence organizationally outside our ambulance service there. And we basically let them know the criteria for referrals and do contractual work that way.
Cool.
Yeah.
One of the things that occurs to me as I work on the ambulance is repeat callers, people who go to the hospital quite a bit and use our services repeatedly. We all have people like that in our service area, and oftentimes it's for chronic problems, and the emergency system just isn't set up to deal with those, right?
Right.
So has North done any studies or statistics, or have they ever looked into, can a CP effectively reduce that repeat call volume, thereby leaving your ambulance coverage intact for other, I hate saying emergencies, because something chronic can be emergent, right? I mean, it can be very serious and detrimental if you don't take care of it, but something that needs to be taken care of urgently, immediately. Do you see a reduction in those repeat calls?
We do. And actually, we do that. We run a high utilizer list every month. And basically, we look at people who have engaged the EMS system 3 or more times in the last 30 days. And then we call them and offer them a community paramedic visit. And we go in and try and engage and again, figure out where those breakdowns in healthcare are coming in. And then we have started tracking 6 months prior to a community paramedic intervention and 6 months after community paramedic intervention. And we've seen some really good results. Now, if you have somebody who's calling 12 times a month, really good results mean they're only calling 4 times a month. Mm-hmm. And sometimes they're calling 9 times a month and they go down to once every other month or
sure.
Once every 3 months.
All matter of perspective, but any reduction in my book is a good reduction as long as somebody's not getting the services and the healthcare that they need, and not missing out on something or whatever. Yeah, I think of that quite a bit, and it almost feels counterintuitive because well, why would we want to stop those 911 calls? But my guess is that payer mix isn't fiscally responsible for the ambulance service. I mean, because let's be honest, at the end of the day, we have to have money to keep the lights on and keep our medics trained and buy equipment. So we do need money, even though we're not 100% altruistic. But it sounds counterintuitive. But I think in the bigger picture, my feeling, in my opinion, that in a quarter won't even get you coffee, but is that it would ultimately be very fiscally responsible for a service to do.
It certainly is, because if these patients are uninsured and don't have the capabilities, we're not getting reimbursed for that anyway. And a lot of insurance companies, unless they meet the criteria, aren't going to reimburse for a what they deem to be a non-necessary ambulance transport. And so you're still having those paramedics going out and doing the calls and maybe bringing somebody in, but it doesn't necessarily tie a dollar amount to it.
I remember in the my old days of ambulance billing, and that was like, I know I don't look this old, but well over 2 decades ago, Medicare would do something called we called it retroactive medicine, right? So your crew shows up for a call and it presents like a stroke. And so you take the person in the hospital and they have a transient ischemic attack, a TIA. And then Medicare would turn around and go, well, they didn't need an ambulance because it was a TIA, not a stroke. I mean, and of course, we don't have a CT in our ambulances to make that determination. We just do the best we can. But then, we eat some or all of that bill. I don't know if that still happens or that's a problem, but that was one of my frustrations with the system always.
Well, I did have the opportunity to sit in once and listen to a Medicare trial where a gentleman's wife was paraplegic, comatose, vented, and had been transported. And Medicare was trying to say that it was not a necessary ambulance transport. And she had since passed, and this poor man was stuck in this position of trying to win his case. And it came down to documentation in that particular case, but I don't think it's uncommon for organizations to not get reimbursed because it doesn't fit the right code, even though it is.
And that's all this assignment stuff aside, which is for those, I know, but for those watching, Medicare says, here's the price structure based on your service or what level you're giving and et cetera, et cetera. And here's what you get. No dickering, no arguing. And many times it's not even enough to cover the salaries of those paramedics on the ambulance, the wear and tear in the truck, and the supplies they used. So even if a CP, even though you can bill for a CP, as I understand, if it's part of the care plan in Minnesota, at least there's a statute that addressed that. Even if you don't get reimbursed for that, it could be financially important to prevent that other loss.
Right. Yeah, it's more of a cost savings program, really. The benefit is there than it will be what we're generating monetarily. Medicaid is right now the only insurance that will reimburse for a community paramedic visit.
Okay, so Medicare doesn't at this point.
They do for transitional care management, which involves a physician.
Got it.
Yeah.
Yeah. Well, and all the paramedics out there watching this right now, their eyes are glazing over because we're talking about billing. But this is, folks watching this is really important because we do have to keep the lights on and pay your salary and pay to paramedics are expensive and the toys that come with, right? So we still need to be offering retirement plans and things. So I think every paramedic should be really concerned about this kind of stuff and at least know the basics.
For sure.
We've got a few minutes left here. Any parting thoughts or words of encouragement, warnings, anything to these folks watching now who are going to get into this line of work? Do's, don'ts, run scared, I don't know, whatever it would be.
I think the one thing that I've most consistently heard from people when they either start community paramedic school or community paramedicine is tempo. We're very much built as people who come in, come out 20 minutes, 40 minutes. We're going to fix the problem and let's go. As a community paramedic, you get more time that you should utilize because it's not going to be we're going to fix it and go. If somebody's had something going on for 20 years, I assure you're not going to fix it in one visit or 1 week or, it's going to take time. But there are few things more rewarding than seeing people make positive changes in their life that literally affect not only their lives, but the lives of the people they love. And so perspectives will shift a little bit. And the other really kind of cool, fun thing that happens is once that starts happening, you're going to see a completely different dynamic in the 911 patients you see. It's not even intentional. It's just all of a sudden you start looking at your 911 patients differently as well. it's a wonderful field, and it's fun to be able to, instead of just having your 40 minutes and leaving somebody, it's fun to get to watch people make progress and see how that really changes their life. So,
And you get to know them and have a rapport with these folks, and you actually know who they are when you're walking in, which has got to help tremendously as far as, they call it a therapeutic alliance and these kinds of things, right?
oh, for sure. Because what they may not tell you on the first or second visit, they can't wait to tell you about on the third and fourth visit. And that's when you really start getting to the core of what's going on. So,
Sure. All right. Well, thank you very much for your time. And hopefully we'll hear from you again.
sounds great, Chris. Thank you.